Pennsylvania, Trends and Insights. We'll be covering melanoma and prostate cancer. Before we begin, I'd like to give a big thank you to the Pennsylvania Breast Cancer Coalition for sponsoring this and for providing our technology. We appreciate their generosity today to get us all together on the phone to continue to learn more about the trends in cancer. I'm your moderator, Julia Bucher, and before I introduce our speakers, I'd like to briefly review our format. We will hear about 10 to 15 minutes from each speaker, and then we will go to question and answer. If you have a question during their talk, please write it in your chat box on the right-hand bottom side of your screen. We may not get to it, but we're going to take all the questions and answers and type them up, as well as the ones that don't get answered, and we're going to post them with answers on an email to all of our attendees today as a follow-up. When we're finished with question and answers, we're going to review a few resources for more information about these two cancers and also talk about some upcoming webinars. And at the very end, we want you to fill out a survey about today's event. With that, then, I'd like to move on and present to you our two speakers. Dr. John Kirkwood is with us today from California, and he will be talking on melanoma. He's the Usher Professor of Medicine, Dermatology, and Transitional Science at the University of Pittsburgh Cancer Institute, and he's also the co-leader of the Melanoma and Skin Cancer Program. After we hear from Dr. Kirkwood, we'll hear about prostate cancer from Dr. Clements, who's a physician practicing with Urology of Central Pennsylvania. Dr. Clements is board certified with the American Board of Urology, and he's also a member of the American Urology Association. Before they begin, I'd like to acknowledge our data sources. Of course, we're using Healthy People 2020 and the latest report of the burden of cancer in Pennsylvania. Our collaborators putting this information together with our speakers are employees of the Pennsylvania Department of Health in 3 different sections. The Bureau of Health Statistics and Registries gathers the information about cancers in our excellent cancer registry and also supplies information from the death certificates. The Division of Health Informatics uses EpiQMS and analyzes data supplied annually from the CDC through the Behavioral Risk Factor Surveillance System, puts those together in great cancer brochures. If you want to use them, they're on their website. And the third section helping us today is the Division of Community Epidemiology. So thank you for those collaborations. And now we will hear from our speaker, Dr. Kirkwood, on melanoma.
Good morning, Julia. I trust that the transmission is going to everyone, or do I need to hit the #1 that it instructed me to do before speaking here? Do you know? Hello?
I think we're hearing you just fine, so go ahead and proceed.
Well, good morning, everyone, from San Francisco, where the Society for Melanoma Research is meeting, and these statistics are even more relevant than ever to our meeting here, as I hope they are to all of you. The next slide will, I think, open the presentation, and while we're getting to that, I want to thank the Department of Health, the Bureau of Health Statistics and Registry, and the Division of Health Statistics and Informatics for the state, because these numbers, I think, are germane to us all. For the melanoma death rate in 2012 is what we'll get to here. The goal to see us at a level of 2.4 deaths per 100,000 population is one that I hope we can even exceed. And for all persons in Pennsylvania, the statistics, as you see, 2.6 for males, 3.8 for females, 1.8 are clearly a concern for all of us. Next slide, please. So the data we have comes from 2010, 11, and 12, and I think what you see here is a rate that has been relatively stable at 4.4 to 3.8 for males and 1.9 to 1.8 for females over the span of 3 years. The next slide. And graphically, I think this speaks more to all of us, where you see the figures for males in the state creeping slowly up if we try to integrate the lines, and for women certainly not rising to the same extent, but certainly equally important, not falling. Age adjusted by race, I think it's important for all of us to remember that this is a disease of light-skinned, sun-sensitive individuals, and the data for whites is clearly the most alarming. For African Americans, it is substantially less, but also to be noted a different disease, where in African American and even in Hispanic populations, melanoma we see is not of the skin in general, but more focused in acral or plantar palmar sites, mucosal sites, and so important not only lower but a different disease, as you see here with the Hispanic rate 2.3 to 2.5, and for the data we have on African Americans 0.9 to 1.0. Next slide. So age adjusted by gender here, you see this rise that we saw graphically before for men, and relatively stable rate for women, both at a level that is higher than we would hope to have in our fair state of Pennsylvania. The next slide. And so here, again, the incidence figures per 100,000 rising, as you see, over the span from 2000 now to 2011, inexorably rising. This is an epidemic in modern era that is eclipsed of virtually all other solid tumors, and is one that is projected to rise in studies that we don't go through today in detail, straight through the 2027 window of time, more than a decade hence. There's no fall in this incidence in sight for us. It is important to note for you, not illustrated here, that Australia, New Zealand, where they've had sun prevention campaigns that we'll come back to discuss later, these incidence rates are actually falling now for the first time in history, and I think we should take a cue from them. Next slide. So here, the incidence and mortality now shown, the incidence in dark blue or purple and the death rates in orange show you for white males this rising incidence associated with the 25.7 per 100,000, but a death rate of also notable proportions with 5 per 100,000 deaths due to this tumor. And in women, a somewhat lesser incidence at 18 and a death rate of 2.1. Next slide, please. So geographically depicting our state here, one sees the areas where the incidence for men is significantly higher in orange, and curiously, these are in the eastern, southeastern areas surrounding Philadelphia and in Bucks County, whereas the west and north of the state show a somewhat lower incidence than on average, but the vast majority of the state are fairly homogeneous, as you see here illustrated. And I think the numbers of invasive cancers here depicted in the round circles show you where we have major foci of this disease. Again, Philadelphia on the far east, Allegheny County and Pittsburgh where we are on the west, the largest numbers that you see, but notable focuses in the center of the state, in the northwest, in Erie County. So, next slide, please. For women, on the next slide, you see the same general pattern with the hotspot, if you will, significantly higher incidence rates in the eastern portion surrounding Philadelphia, somewhat lower in the western, the southwestern portion of Allegheny County and our area. Next slide, please. So mortality on the next slide will be depicted for men, and the male focus of increased mortality. Bucks County you see on the far east, and Allegheny County somewhat less, the far west in blue. For women, the next slide, the female mortality rate following generally similar patterns. Again, mortality highest in the Philadelphia area, and generally elsewhere significantly not determined. Next slide, please. So the counties here listed where the incidence is higher. We've seen them graphically depicted before, but for men, the far east, for females likewise, and I think you can all read these counties. I don't need to recite them for you. The next slide, please. And for mortality, again, among males, Bucks County, and among females, Delaware County, but very proximate areas for this focus of a higher mortality in the east of the state. Next slide. So the staging data is interesting because, as you all know, invasive melanomas with either local, regional, or distant disease are only half or less of the problem. In situ melanomas, where the problem of reporting is one that we need to recall, is there because this is easily, in the U.S., 70,000 cases versus 60,000 of the invasive melanomas, but we also show here a striking number of both male and female white patients with melanoma in situ. And if we had complete reporting, I think we all anticipate these would eclipse the number of invasive melanomas. In orange, we have localized disease, and as you all know, the vast majority of melanoma that we see across the state is found localized happily in stages 1 and 2, and a somewhat lesser distribution of regional disease. The green that you see here, and distant disease, happily the mortal disease that we face with melanoma, the least of all, 3.8 and 2.8 for the male and female population, and unknown for a small fraction of about 5–6%. Next slide, please. So hospital admissions, the cost to our economy of this disease, show a relatively stable trend, slightly heading downward over the past decade, illustrated here between 2001 and 2011. Because of the incident numbers that we've already gone through, these are somewhat higher for for male patients than for female patients, but this is a significant cost of the disease in terms of hospital admissions caused by this malignant melanoma, cutaneous melanoma. Next slide, please. So charges by primary payer type, something that we all also need to focus upon. Here showing a substantial rise in general between the 2001 and 2011 windows of time for which we have data presented, with commercial carrier insurance and Medicare insurance the largest part of the support for the costs of care of melanoma. Smaller fractions that are Medicaid, as you see in the orange bars, and happily a relatively limited fraction of people who are uninsured in our state and require care for this tumor. Age-adjusted here, hospitalization rates by ethnicity, I think predictable from what we talked about before, with the burden of the disease, largely Caucasian patients. And I think this is self-explanatory in terms of the distribution of disease and its age-adjusted hospitalization consequences. So I think all of this, happily, a couple of years ago led to the Surgeon General's call to action that knowing that the vast majority of melanoma is associated with UV carcinogenesis in the skin, our largest organ, is to avoid midday sun exposure, avoid recreational sunbathing, wear coverage of your arms and legs when you're out, clothing that is sun barrier and would prevent the damage that is associated with UV, to wear sunglasses that protect the eyes from UVA and UVB, and to use sunscreens, particularly those that contain zinc oxide or titanium dioxide, which have the ability to block sun penetration to the skin and the damage that is associated with UVA and UVB. Finally, to avoid indoor tanning, as you all know, we finally have some legislation that seeks to do this, but still an incredible number of indoor tanning facilities that have usage that is far beyond what any of us who deal with melanoma think can be in any way tolerated. Next slide, please. So with that, I'll thank you all for your attention and turn the podium back to Julia and to Thomas Clements.
Thank you very much, Dr. Kirkwood. And next we have Dr. Clements discussing prostate cancer.
All right. Well, thanks for having me here. Thanks, Dr. Kirkwood, for that great explanation. And we can now get started and talk a little bit about prostate cancer. So next slide. Okay, so prostate cancer and the PSA have been in the news quite a bit the last few years. In May of 2012, the USPSTF came out with a grade D as in dog recommendation, which basically meant that they recommend against screening routinely for prostate cancer. And that was a blanketed statement that really applied to all men regardless of race, age, or any other risk factors. Now, we could talk about for hours and hours, and we have had meetings about this for hours and hours, but to say the least, that's something that we as urologists really disagree with and are actively trying to make the appropriate changes from a legislative point of view to try to highlight some of the data that's out there that shows that it's actually beneficial to continue to use the PSA to screen people for prostate cancer. Now, the American Cancer Society do recommend that patients have an opportunity to make an informed decision about whether or not they should be screened for prostate cancer. And that's really what we highlight, is that it's not just a simple number that we say, yes, do this, or don't do that, but it should be an informed decision and a conversation that a patient will have with a patient and their urologist about what these numbers mean and what the next step should be. The other cancer societies, the NCCN, as well as the American Urologic Association, do recommend PSA screening. Next slide. Okay, so here we're talking about the cancer death rates here. So the goal is a rate of 21.2. If you look at where we are now in 2012 here in Pennsylvania, the death rate for all males, 19.1. And then you can see how things change depending on race here, with whites at 17, black males at 48.6, and Hispanic males at 16.5. So you can see that, clearly there's a significant difference in cancer rates, and we'll see that along with other factors here that we looked at. There's a big discrepancy between white males and black males when it comes to prostate cancer statistics. Next slide. Okay, so we're looking at the incidence of prostate cancers, age-adjusted here throughout the last 10 years or so. And we can see that there has been a slight decrease from 2000 to 2011 for black males, starting at about 250 and then working down to around 200 for the latest number. The remaining races have remained fairly stable with a slight trend downward, but not very significant. Next slide. Now, when we look at mortality, there's some variability as time has passed, but in general, it's held steady with a slight decrease in the rates as time has passed, and that very well may be due to some advances in treatment options that have come out, as well as the use of the PSA. Next slide. So this is a great slide to really highlight a few things here. We're looking at both the incidence and the death rates for prostate cancer here for all Pennsylvania males. And I think something to highlight here is really the incidence, where that peaks there. If you look down from where the blue line with the square blue blots are and look down at those ages, the highest incidence really occurs around ages 65 to 70. And that goes along with some other data that we have to look at, more national data that shows that the average age that a man will be diagnosed with prostate cancer is age 66. And then, of course, death rates go up as time passes here, which is consistent with just the progression of the disease. It's a fairly slow-moving, slow-growing cancer for the most part, but there certainly are cases that don't follow that typical expected routine. Next slide. Okay, so when we look at areas that have the highest burden for the incidence of prostate cancer, we really hone in on these counties that are in orange. And you can see as we surround Philadelphia, Bucks County, Montgomery, and Chester here, along with Philadelphia and Delaware, that there's a significantly higher incidence of prostate cancer. In Philadelphia itself, we have a higher number of invasive cancers, as noted by the larger red circle. And then when you look at throughout the rest of the state, there are some lower areas as you go from Wayne County down to Cumberland County, and then in Clarion and Jefferson and Warren, in that corner up there, we see another jump in significantly higher incidence of cancer. Next slide. As for mortality for prostate cancer, we really hone in on the county of Philadelphia, where we see a significantly higher incidence of prostate, or higher mortality of prostate cancer, along with a greater number of invasive cancers. But when you look at the rest of the state, it's quite homogeneous, and we don't see that higher mortality paralleling the incidence like we do just in the county of Philadelphia. Next slide. So looking at staging distribution, the orange bar, as we see there, that is a local stage when someone is diagnosed with prostate cancer. And we're comparing white males, black males, Asian males, and Hispanic males. And in general, the numbers, the distribution of local prostate cancer is fairly steady and equal amongst all of these populations. That is similar in the regional staging of prostate cancer, as you can see by the darker purple bar. That hovers around 11 and 13 for all demographics. But it's interesting to really point out that you see a discrepancy amongst some of the groups here when it comes to distant prostate cancers, or really metastatic prostate cancers at the time of diagnosis. And you can see that in Hispanic and white males, that number is around 4, but it really jumps up in black males and Asian males with numbers of 7 and 9. Next slide. So when we talk about prostate cancer survival, I think I mentioned this before, it's known to be a slow-growing disease. There's lots of catchphrases that people like to use about prostate cancer, that you will have prostate cancer, but you may not die of prostate cancer, that it's very slow-growing. And some of these concepts and ideas are the things that drove the task force to really downgrade the recommendations for screening for prostate cancer, thinking that, well, perhaps it's not even necessary. The good thing is that because of the pathology of most prostate cancers, the survival rates for prostate cancer are very good when it is caught early and is still found within the prostate. And that's what this is telling us here. The relative survival rate for invasive prostate cancers was 98.9%, which is great. But when you look at distant stage cases where the prostate cancer has already spread to the lymph nodes or perhaps to the bones, the lower spine, that drops significantly down to 28.2%, which really, again, emphasizes the importance of catching this cancer early before it spreads outside the capsule of the prostate. Next slide. So, kind of echoing what we looked at on the map here in terms of incidence rates and death rates, we can really see who is at the highest risk for not only getting prostate cancer but also dying of prostate cancer. And you can see that the highest burden population is really a black male. They have a higher rate of getting cancer, and then as we saw with some of that staging data, they're at a higher risk of presenting with distant stage disease, which will lead to higher mortality rates as well. Next slide. So this is, again, paralleling that county data that we looked at with significantly higher incidence rates of prostate cancer between that time frame. And if any of the listeners are out there, I think it's important to recognize which counties are having higher rates, and to really keep in mind the importance of looking for prostate cancer, especially in Philadelphia County and Montgomery County, where the highest rates were and the highest number of cases in the state were. Next slide. And again, here we're talking about mortality rates with counties with a significant higher rate than others. And once again, we're talking about Philadelphia County with 937. Next slide. So the big question here is, why are black men negatively affected by prostate cancer compared to white men? And certainly this is a complex question with more than one right answer, but we know based on our studies that it has to do with genetics, that the DNA and the biology of African American men predispose them to a higher risk of prostate cancer. That, in combination with a variety of other socioeconomic factors, which may lead them to perhaps not have access to care, then let the symptoms drag on for a little bit before they eventually get diagnosed, then they end up with later stage diseases and higher mortality rates. Unfortunately, we don't have as robust studies as we would like that would be looking specifically at black men. A lot of the studies have mostly white men in them, and so as time passes, we're trying to get more data that is race specific to be able to really figure out why this is the case. And of course, the American Cancer Society has much more information on this on their website. Next paragraph. Okay, do I turn the time over to back to you, Julia?
Yes. Thank you so much, Dr. Kirkwood and Dr. Clements. We have plenty of time now for questions and answers, and then we have 5 more slides right before our wrap-up at 12:15. I'm going to read and direct the questions next. To Dr. Kirkwood, what is the staging of melanoma?
So melanoma is, am I online, Julia?
Yes, you are.
Yes, good. The staging of melanoma is broken up into localized thin, localized thicker, regional lymph node, and distant disease. Stage 1 is the stage 1A is the thinner melanomas, sorry, and those actually in stage 1A, thinner than a millimeter without ulceration, have an excellent prognosis. And so this is the impetus for all of the community physicians and our participants to really make an effort to pick disease up by simple skin examination on an annual basis. Because if disease is picked up in stage 1A, thinner than a millimeter with no other adverse factors, the prognosis is excellent. Well past 10 years, 90% of people will survive without recurrence or problems from this disease. When one microstages melanoma at the primary site, the thickness is the dominant factor that plays a role in this, and the thickness in increments of a millimeter, the T1 under a millimeter, T2 up to 2 millimeters, T3 up to 4 millimeters, and T4 over 4 millimeters of thickness of invasion, what is called Breslow thickness, define the microstages of primary melanoma, and whether a patient presenting with such disease is classified as stage 1A or 1B. For the thicker cases, stage 2A or stage 2B. When the tumor travels, it travels predominantly initially by the lymphatics, and that is the reason why sentinel lymph node mapping is crucial to understand the stage of disease and the burden of the tumor in an individual patient. Any patient with melanoma over a millimeter, according to the current guidelines, and perhaps in the next edition of the AJCC staging system, which we discussed here in San Francisco on Tuesday, maybe even over 0.8 millimeters, will be of sufficient risk for travel to the lymph nodes that a mapping procedure is indicated. This is called sentinel lymph node mapping, and is part of the staging indicated for melanoma to determine whether regional lymph nodes are or are not involved. If they are, this takes the patient into stage 3, where stage 3A is low burden regional lymph node disease, a microscopic involvement of 1 or 2 nodes. And stage 3B is bulkier disease in the regional lymph node basin. And stage 4, I think, is in all other cancers, is distant metastatic disease with the highest risk of complications of disease and of mortality.
All right, well, thank you very much. The next question is for Dr. Clemens. It's about indicators for prostate cancer. Why the big debate for using PSA as an indicator, and are there other indicators for prostate cancer?
So I think it's important to understand what exactly the PSA is. That stands for prostate-specific antigen, and it is a small protein that is secreted by the prostate into the bloodstream, which we are able to test through a simple needle stick, and then we get a concentration. Now, historically, we've seen things evolve with PSA, and in the past, we used to use the number 4.0 as a worrisome level, that if someone had a PSA over 4, it would be concerning for prostate cancer, and we would eventually lead them to a biopsy. Now, as time has passed, we understand that the PSA is not a perfect test, and it needs to be interpreted wisely. We also know that as time passes and as men age, the PSA naturally will go up because men's prostates are getting bigger as they get older. So we now know that there are age-specific PSAs, different cutoffs that we use to stratify one's risk for prostate cancer, and we no longer just use the 4 level as a cutoff. So with that said, PSA is still valuable, but it just needs to be interpreted correctly. There are other tests that we can look at to stratify one's risk for prostate cancer. The PSA can be chopped up into pieces, and we can look at something called a total PSA as well as a free PSA, and then the percentage-free PSA. That gives us some more information about one's risk. In addition, we have some newer tests that we can use that help kind of put the check marks in the pro versus con boxes to decide if someone should proceed with a biopsy. Some of those are urine-based tests. One of them is called a PCA3 test. We also have a test called a prostate health index, which is another blood test that we can use to really decide if we need to do something above and beyond screening and move to a biopsy. And then lastly, there are some newer technologies using MRI as well as ultrasound and fusing those images together to look for any suspicious lesions and then deciding to proceed with a biopsy. So to say the least, I think the big debate has been that we understand it's not a perfect test, but it's still a valuable test and needs to be interpreted by someone like a urologist to really understand its value.
Thank you for that explanation. Dr. Kirkwood, this question, you may have already answered it. How does the thickness of the melanoma affect the outlook for the patient? Sounds like it really matters.
Yeah, I think it probably bears emphasis because on one side it is so simple and so straightforward, and on the other side there are so many nuances and subtleties to what we mean. But I think when I talk with patients about the importance of thickness, I like to make analogy with the height of a building, if you will, and really per millimeter, the risk of relapse at 5 years goes up by about 10 millimeters. So vertical invasion of melanoma, what is called the microstage, the T1, T2, T3, T4 groupings that I already mentioned, are critical to be able to assess. So what does this mean to us? It means that when you do a biopsy of a lesion suspicious of being invasive melanoma, you really want to get the whole lesion, the whole thickness of the lesion. And that is a reason that we don't like to see partial biopsies. What are called shave biopsies. I don't include here the deeper saucerization biopsies that actually take the whole lesion. But since vertical invasion is critical to microstaging of melanoma, a complete excisional biopsy is important. The other corollaries that are important to mention that I didn't mention before have to do with the top of the tumor, if you like, the roof of the building, because if the roof is blown off, if it is ulcerated, we have clearly, repetitively shown that the risk of that particular melanoma is substantially higher. So a 2 millimeter thick melanoma that has ulceration overlying the tumor actually is like a 3 millimeter melanoma, and we in fact have accorded this B substage grouping in our system, so that a tumor without ulceration is the A category, and a tumor with in general is the B category. The other corollary of that is if you leave part of the basement of the tumor in the biopsy, or if the deep margin of your initial biopsy is positive, you never really can be completely sure what the Breslow thickness, the vertical invasion height, if you like, of the building is. And this, again, qualifies our assessment of the risk of that particular patient. And so I think the thickness of melanoma is something that is crucial to understand for each patient. And when you know the thickness and that it does or doesn't have ulceration, that it does or doesn't have deep margin positive, you're then prepared to do the microstaging of the local disease generally in the skin.
It really is a specialty. Well, thank you for that. And we have time for one more question. I want to remind our attendees that we will be sending out all the questions with their answers from our speakers to you on an email. So we will get to them all. But in terms of our time on the webinar, I'm going to ask Dr. Clements one more question, and then I'm going to wrap up with a few slides. Dr. Clements, how common is prostate cancer?
Great. So I think we can look at a few things. One, prostate cancer is the second most common cancer in men. It's also the second leading cause of cancer death in men. Well, then that's only behind lung cancer. If we looked at some numbers, what we anticipate for 2015 here in the United States, we anticipate to see about 220,000 new prostate cancer diagnoses, and we anticipate to see about 28,000 deaths from prostate cancer this year. You still there, Julia?
So Thomas, I'm hearing you, but I don't hear anything else. I hope everybody else is still on.
I don't know. I can hear you.
Yeah. So maybe we lost Julia.
Maybe there's a little text box over to the right that I texted something, but I didn't see an answer quite yet.
We're going to take over here in the technical in the background here and do the last couple slides since we lost Julia. So this is just a slide. It just has some more cancer data, areas where you can find more of the statistics and everything that was reported today. Here's some additional resources that the presenters wanted to provide to us. AIM at Melanoma for melanoma, of course the American Cancer Society, the Melanoma International Foundation, and the Pennsylvania Prostate Cancer Coalition for prostate cancer. There is going to be a more in-depth review of melanoma and thyroid cancers that's going to be conducted by the Data Advisory Committee. They're going to take the information and kind of narrow down a little bit more at disparities and some of the geographic information in that. This is the information to be able to log on to that webinar. And then this is an upcoming webinar. It's the next one in the Cancer and PA series. It's on radon, Thursday, January 7th from 11:30 to 12:30. We will be sending out information as far as how to register for this webinar. And for this webinar, there are plans to have CMEs available as well. All right, thank you for attending the webinar. If everybody could take a moment and do the survey after the webinar concludes, we would appreciate it. Thank you very much, and have a good day, everyone.
Thank you all.
Thanks.